Good morning, everyone. My name is Mirza Pojskić. I'm neurosurgeon from, actually from Zenica, Bosnia, but in Philipps University in Marburg in Germany since 2013. And I have a hard task after Samir said that Germany is the third world country to show that we have some tech things which are now at the peak of the modern medicine. Augmented reality in spine surgery was actually, we hold a patent on that because we are the first department in the world which produced a big series on augmented reality, not only case reports or proof of principles, technical notes, but a real series where its application has been shown in many ways. And we are still at the very beginning of all possible applications of this technique and working very hardly and together with the industry to make it better and more prone for use. So this is one part of our publications on augmented reality which came from our department in the past several years. And we've just published 3 papers in the last 2 weeks on use of the technique for intradural spinal tumors, for acoustic neurinomas, and for herniated thoracic discs. I'm going to show the applications for thoracic discs and for intradural spinal tumors. So we have an intraoperative CT. We have intraoperative imaging-based registration, which does not need patient or user interaction, so it can be automated. We have low-dose protocols which allow for significant reduction of effective doses. And this is our operative setting. I'm sorry that the publication is going wild. So this is our operative setting. The positioning of the patient, the position of the navigation camera, intraoperative CT, the table, the C-arm. And we do preoperative imaging, image processing, intraoperative scanning, automatic patient registration, nonlinear registration of the navigation plan. In case of repeat ICT, the subsequent ICT scans, which are scanned with the automatic registration setting. And so what is augmented reality? You have virtual objects which are overlaid in a real-world environment. You have the real environment, augmented reality. You have the augmented virtuality and virtual reality, which is the next step, immersion in a fully digital environment. So it's a significant advance which provides a real-time updated three-dimensional virtual model of anatomical details, which is overlaid on the real surgical field. And it allows to overlay 3D projections from preoperative images into bilateral eyepieces of the binocular optics of the microscope. We've used ICT for spine surgery in the beginnings, mostly for screws. And then we've started to use it to combine augmented reality. So for spine surgery, first case report on it was from Abe in Journal of Neurosurgery Spine, and Elmi Terander at 2016, and Lieberman, which are all different assets, how to use augmented reality with microscope, with smartphones, with augmetics glasses. But we believe that since the microscope is the core of our neurosurgical way to treat lesions and to operate, we find that the microscope-based application of this technique is actually the best. And this is the first experiment which we've done in our department. We've scanned a model of the spine, and then we confirmed, then we did an auto-segmentation of the vertebrae, of the nerves, and of the discs, and then got a three-dimensional reconstruction in time. And following that, we've started to use it in real-time surgeries. So most important thing, if you want your augmented reality to work, is that your registration and navigation works. And navigation works only if you have a very good placement of the reference array, which is in the proximity to the surgical field. And it is amazing to see that you don't always have to dock it on the spinal process or on the hip, but you can also tape it very firmly, just proximal to the operative field, and still get a good registration accuracy. And you can check that registration accuracy like here, where you have the augmented outline of the reference array and the reference array, and when you see that they have 80 to 90% parallelism, then you are on a good way. This is also one from our publication, the operative setting when you use it for spine. So this is the operative microscope. It has an additional reference array. The navigation camera shows the navigation camera looks at the reference area on the patient and on the reference area on the microscope and on the reference area of the ICTs. And in that way, you get a three-dimensional image during the entire surgery. When you start to use it, it's very important to perform a navigation accuracy check. You can check the accuracy of the navigation on anatomical landmark. This is one lateral case, implantation of the expandable body implant via a lateral approach. This is the XLEF retractor, and you can check the navigation accuracy very easily using your pointer. Then we've used it also for herniated discs. This is from the initial experience. When you do a thoracic herniated disc via a lateral approach, these are the outlines of the vertebrae. This is the outline of the herniated disc. And when you have a situation that you have a very stiff and very calcified thoracic disc, then when you open it in a transthoracic or a retropleural approach, you usually do not see any anatomic landmarks that help you whatsoever. And near the neuromonitoring, this allows you to know where the lesion is which you need to drill out or to decompress. We've just published this case series of several cases with thoracic herniated disc which were operated in this technique through the transthoracic approach. Also following the intraoperative CT which we use for the implant control, you can also do the implant as a augmented reality asset and then do reconstructions like this. You can also now do it pre-operatively with AI models for planning of surgery and for planning of deformity correction, which then allows you to reconstruct or to know your wishful result at the end of the surgery with the implants which you actually use. And this is one video of the resection of the herniated disc. So for thoracic discs in general, we always use the lateral approach. For big thoracic disc, herniated thoracic disc, this is a patient who was operated in an external institution. They've performed a hemilaminectomy. It was a big herniated disc, T7-8, and of course the patient got worse following the surgery. One additional option is to perform the surgery through the joint. This is preoperative CT with a large calcified herniated disc. These are the intraoperative images, preoperative and postoperative. You can do the segmentation of all the structures and then follow throughout the surgery the whole time, what are you doing and where are you at every moment of the procedure. So the light is here not optimal, but you can see here that you have the outlines of the vertebrae, you have outlines of the herniated disc, and it is often that in cases where you have a completely calcified situation that you, in a context of lateral surgery, you don't have any landmarks which you can use whatsoever for any kind of orientation. And just fast forward, this lateral approach itself is very helpful for because you avoid the manipulation of the spinal cord. And there are now also applications of endoscopy. You can put augmented reality into endoscopy, and if somebody likes to operate this using endoscopy, you can also have this anatomical three-dimensional reconstruction which then helps you to do an update of the whole procedure. So this is once more. This is what I wanted to show. Okay, we'll just move forward because the video is pending. So this is the preoperative CT or intraoperative CT prior to surgery, reconstruction of all the structures of interest. This is the intraoperative CT and fusion of images, preoperative, intraoperative. This is the XF retractor. This is the reference array, and this is the intraoperative situation. And this is the end of the surgery, where you see the segmented dural sac, and this is the amount of the compression with the herniated disc. And this is the herniated disc or the complete, this is a three-dimensional reconstruction, so we drill out the posterior third of the vertebrae. And you can do it in 2D, in 3D, and if somebody is uncomfortable to have these lines throughout the surgery in the binoculars of your microscope, you always have a chance to shut it off and still to have augmented reality on head-up displays which are disposed in the OR theater. And this is the preoperative image with the segmented disc, and this is the intraoperative image which shows the complete resection, and this patient recovered fully. You can also do it in anterior approach. This is not always necessary, but as a proof of concept, it helps if you want to do tailored resection. I think it will help a lot for primary spinal tumors such as osteochondromas or chondrosarcomas, where it's really important to get the complete tumor out, and you have these outlines. It can also help you master the desired extent of resection. You can do it in neurovascular structures or for reconstruction of screws and for intradural tumors. We've published 2 weeks ago a case series of 120 cases which were operated using this technique. This is one hemangioblastoma, and or for meningiomas, and hope that this video is going to work to use it in. Okay, I can show it from another publication. And this is one recent case which actually very clearly shows why is this technique very good. This is one recurrent schwannoma with bony erosion operated 25 years ago, which now developed a foot drop. And this is the extent of resection. This is a big cyst of this tumor, and this patient needed a surgery through the scar tissue. We've performed an intraoperative CT, which allowed us then on the bony structures to perform a navigation update and with the outlines of all the structures. And this is another intraoperative image. So we've combined intraoperative CT, preoperative MRI, intraoperative 3D ultrasound, and the outlines of all the tumors. And this is the beginning of the surgery. This is this scar tissue. And in this scar tissue, there is no way to get your way around it, where actually the tumor is, where are the important nerves, where are the other structures. And you see throughout the surgery the outlines of the structures which you want to operate. And this is the visualization which you get. And when you focus the microscope on the tumor, this is that recurrent schwannoma, you see that the outlines of the structures are actually very parallel or very accurate compared to that what you have segmented previously. And it's very interesting that in intradural spinal tumor surgery, you do not have any movement of these structures, although you have a CSF release. So otherwise, as in the brain, when you have a brain shift, when you release the CSF, you don't see this effect in intradural surgery. So this is also one photo from our intraoperative, and this is how it looks during the live surgery. You look this through the binoculars of your microscope, and you adjust the focal zoom of the microscope, and you always can see how deep you are, where are you, and what the structure does come next. You can also check the accuracy navigation with a pointer the whole time, and this is throughout the surgery. And we also have integration of three-dimensional ultrasound. We do an ultrasound, navigated ultrasound, 3D scan connected to the pre-planned, to the intraoperative CT and the following navigation, and then you have all of these structures in all possible ways in three-dimensional, which you can also then use for extent of resection. One of our projects is to make a navigated ultrasound for the intradural spine tumor surgery, which then does not need an intraoperative scan, but where you can do a point surface matching and very cost-effective then use it. So this is, I'm not sure that everybody can see this very good, but this is how do you obtain this three-dimensional scan, and these are the outlines of the structures from the CT and from the MRI in the intraoperative ultrasound. And this is once more, we have a custom-made intraoperative ultrasound with an ultrasound probe of 18.3 megahertz. That's the only one in the world. And we've published extensively now on its use in cranial neurosurgery and in spine surgery. What's the next big leap? To perform implantation of pedicle screws using augmented reality. There are laboratory that is already happening in a laboratory setting. And there are also some shorter case series. This is a publication from Sweden 2 years ago, which I've also reviewed, and it is very interesting that there will be a possibility to implant an augmented reality screw only using your binoculars without X-ray, without anything. You can also use it with these head-up displays, and following the correct registration, it will be possible to, from the skin, to see the pathology you want to operate on with an additional presentation of MRI, CTs, or what imaging, whatever. And Professor Hertel and his team also published it in a minimally invasive setting. They've also used it for the localization of the lesion. If you have a very small tumor intradurally somewhere in the spine, and following the intraoperative scan, you can, when you look at it through the binoculars, see a small dot where it is, and then put an incision, 1 centimeter incision on that dot on projection of the lesion, and put a tube and operate it then through the tube. So when you look at the trends in augmented reality, neurosurgery, spine surgery, the trend of publication is highly rising. And so the most important things, take-home messages: automatic registration, re-registration during the procedure, immediate intraoperative quality control, and you have objective evaluation of the intraoperative situation in cases of very large tumors with important relations to some neurovascular structures. Even if the accuracy of registration is impaired, you still have that sense of a size of the tumor, and you can estimate if you've taken it out in 50, 60, 70, 80, or 90%. So even if the accuracy is slightly impaired, there is still a use of it. It increases the comfort for the surgeons in reoperation. It's a good tool for resident education and estimation of the tumor extent. Shifting of the cord occurs when it is decompressed, and in that way we integrate the ultrasound, allowing an update, and we have a low dose protocols which are implemented, so you can do repeat scanning. Really, the protocol which we use for scanning of the spine has a very low effective dose, and there is no exposure for the staff. So thank you very much. And I apologize for technical issues.